Welcome everyone. My PhD thesis is Imbalance in vascular reactivity between women and men. I'm Ádám, a PhD student, a dentist, and an endodontist. I work at the Department of Restorative Dentistry and Endodontics under János Vágén Kerémi Beáta. My SMS is Petrana, and I work with the statisticians Gergely and Zsolt. My vision is improving the quality of female patients with cardiovascular and periodontal diseases through providing evidence-based data for personalized care. Here's the list of my two specific goals, of which the first one is comparing vascular reactivity between healthy women and men on macro and microvascular levels, a systematic review, and meta-analysis. Cardiovascular diseases are the leading cause of death globally for both women and men. Endothelial cells have essential roles in maintaining cardiovascular health. These roles include maintaining and regulating the hemostasis or angiogenesis and so on. The age-adjusted CVD death rates and incidences are higher in men than in women. And one possible explanation can be that the endothelial cells are targets for estradiol, and this hormone even modulates the endothelial functions. Despite these differences, however, women have always been underrepresented or even excluded from clinical trials. When we want to assess cardiovascular health, reactive hyperemia comes in handy, which is a complex phenomenon evoked by transient ischemia, and it can be utilized even both on macro and microvascular levels in a non-invasive way. However, still, the influence of sex on reactive hyperemia measurements remains uncertain. So our aim is to compare the reactive hyperemia between healthy females and males. Our question: is there a difference in reactive hyperemia between healthy females and males based around the PFO framework, where P1 and 2 is reactive hyperemia on the brachial artery and on the skin? F1 and 2 are healthy female and male. The primary outcome is change in artery diameter, and the secondary outcomes are change in blood flow, wall shear rate, and time to peak. Our hypothesis is that women have higher hyperemia than men. The systematic search was carried out in 3 big databases, and you can see the attached search key here. We started the search with more than 18,000 articles, and after the selection process, we are left with 93 eligible articles. The skin results are still under analysis. However, the brachial artery results are completed. First, I'm showing you the results of the relative artery diameter change, which is the change from the baseline to peak diameter to the reactive hyperemia test. For this analysis, we included 44 studies, and in those studies, there were about 900 females and 1,100 males. On the graphs, on the y-axis, you can see the relative artery diameter change, and on the x-axis, you can see either the age or the BMI, where the other secondary predictor was standardized. And on the graphs, you can see that indeed the gender have a significant effect on the results. When we look into the model analysis, we can see that male gender indeed have a significant effect, lowering the artery diameter change with about 1.2%. And we can see that the secondary predictors both have a significant effect on the result. Our next outcome is the relative blood flow change. For this analysis, we included 10 studies with 200 females and 215 males. And the mean result for the females was a change of 431%. And 375% for the males, with the overall mean of 405% hyperemia. You can also see that the gender's confidence intervals overlap, so there is no significant effect. However, when we look into the model analysis, we can see that also here the male gender have a significant effect. The strengths and limitations of our study are the following. There was a huge number of studies and participants included from multiple countries, and all of the participants were healthy and non-smokers. However, a limitation is that the reactive hyperemia test is a non-standardized method. In conclusion, we can say that female indeed have a higher dilation of the brachial artery with about 1.2%, which might not seem a very big difference. However, in general, we can say that if the arterial reactivity decreases by 1%, it increases the cardiovascular risk by about 13%. And also, the male gender has a negative effect on the extent of hyperemia, so we can say, or this implies, that the sexes should be separated for clinical trials. Here's the progress with the first project so far, and the manuscript status. And for my second project is comparing post-occlusive reactive hyperemia on the gingiva and finger pulp between healthy and periodontitis patients, an observational study. Studies on big arteries suggest that females indeed have a higher reactive hyperemia. This reactive hyperemia can be measured with the method or with a device, the laser specular contrast analysis, which is a good method because this device can even visualize the results by rendering the readings to a two-dimensional heat map. Periodontitis is a destructive inflammatory disease of the periodontium, namely the gingiva, the periodontal ligaments, the cementum, and the alveolar bone, ultimately leading to bone loss, to tooth loss. The disease also remodels the gingival microvascular structure, leading to change in circulation. The disease also has a higher prevalence in men compared to women, just like the cardiovascular diseases. And the disease itself can lead to systemic pathologies as well. And it is also an established risk factor for cardiovascular diseases. Our aim is to compare the post-occlusive reactive hyperemia of the gingiva and finger pulp between healthy and patients with periodontitis. Our clinical question is, could the periodontal inflammation lead to changes in focal microcirculation? Based around the PFO framework, where P1 and 2 are pore tests on the gingiva and finger pulp, F1 is gender, female, male, F2 is gingival status, healthy or severe periodontitis, and the outcome is change in blood flow in laser specular perfusion units, which is the arbitrary unit for the laser specular contrast analysis. Our hypothesis is that hyperemia is smaller in the focal area in periodontitis patients, and the implication is that periodontal disease and its treatment affects systemic health. For recent clinical studies, I'm showing you two, where the pore test was carried out on the gingiva and on the skin, meaning that our study can be carried out. And interestingly, on the gingiva, the effect of sex is the opposite, meaning that a male had a higher hyperemia. As per summary, these were my two ongoing projects, and the planned submission date for the first project is this October. To know is to know that you know nothing. That is the meaning of true knowledge. Thank you for your attention.
I'm always a little bit, probably in the literature is considered as gender. Is it in the paper, in the scientific paper, male and female genders are written? The question is because gender is supposed to be social science differentiation, and we know that it can be quite flexible. The other way, sometimes you mentioned at the summary that sexes may be different. So you are using these two as an interchangeable. Are they?
Well, thank you for this comment. Well, we are looking into the sex differences. I just interchanged this in the presentation to make it more, well, not interesting, but more colorful. It's just for the presentation, but you are right, we are looking into the sex differences, so the difference in genetics and not the socio-economic differences.
So I would suggest you use all along that, unless it's for some reason it's accepted in the medical subjects papers. Any other?
On your last forest plot, we can see that there was a bit outlier study. Can you?
Come again, please.
The last article is a bit outlier. Did you find the reason?
Well, unfortunately, the reactive hyperemia measurements are not very well standardized. We wanted to look into different aspects. As you can see in the comment section, I've written the race of the patients and to see whether this has a significant effect on it, but we will have to look into it more precisely.
I might have missed at the beginning, when you are talking about the females, were they categorized into a premenopausal or a postmenopausal groups, or they are mixed, or because we know that there is quite a difference, right?
Thank you for the question. Indeed, there is a huge difference between females of the reproductive and postmenopausal age regarding the cardiovascular health and cardiovascular status, because in postmenopausal state in the estrogen levels of course decrease, and this comes with a decrease in the arterial reactivity of these females. However, we wanted to look into the constant state, so we were looking into only females of the reproductive age and see if there's a difference between the sexes in that age.
I just want to ask, do you have any hypotheses concerning the second project? And you just mentioned that, for example, it was surprising that in gingiva, the effect of sex was different. Why do you think so? Like, what's the hypothesis for this? Thank you.
Well, this implies that, okay, from the first project, we can say that in general, well, of course, we are checking it on macro and microvascular levels, that there is a difference, mainly meaning that the female have a higher hyperemia, but this shows where on the gingiva that the effect of gender is different, is the opposite. This implies that this can be an organ-specific effect for these. So we will have to, or they will have to look into it organ-specifically as well.